Assalamu alaikum. Let's start our today's discussion with meningitis. In the scenario, they will mention a classical triad of fever, headache, and neck stiffness, also known as nuchal rigidity. It is the inflammation of the meninges, that is meningitis, and not the inflammation of brain itself. When it comes to the causative organisms, it can be caused by bacteria, viruses, Mycobacterium tuberculosis, or malaria. In the scenario of TB meningitis, they will specifically mention low grade fever for a long term, like for months. But in case of bacterial meningitis, it will be a high grade fever and there will be a acute presentation. When it comes to investigations, you can clinically diagnose it by checking the two signs, Kernig's sign and Brudzinski's sign. I have added some related investigations from osmosis that includes the lumbar puncture. It is done for CSF findings such as increased number of WBCs, lymphocytes and PMNs. In case of bacterial meningitis, the number of the PMN cells is increased, while in TB meningitis, the number of lymphocytes is increased. Similarly, the CSF in bacterial meningitis is cloudy while it is clear in TB meningitis. Intracranial pressure is increased in both. Protein level is also increased in both, while glucose is decreased in both. It is increased or decreased as compared to the normal CSF fluid composition. You can also get the PCR done and Zn staining, culture, NAT, and acid fast bacilli AFB to check for tuberculosis. Brain imaging can also be included in the investigations, more specifically to check the raised intracranial pressure. Take a quick look at this table and learn the differences. The level of the WBCs is raised between 5 to 1000 in TB but not more than 1000. If it is more than 1000, the scenario will be more towards the bacterial meningitis. When it comes to the management, if it is caused by TB, you will give the drugs that are used for the treatment of TB. RIPE is the mnemonic that you can remember. And when it comes to bacterial, you will first have to give the steroids to prevent any kind of damage to the meninges. And afterwards, you will treat it with antibiotics as it is caused by bacteria, such as ceftriaxone and vancomycin, and further antibiotics can be added after the confirmation of the particular organism. Complications of meningitis include raised intracranial pressure, hydrocephalus, and brain abscess. Take a quick look at the past paper question. Let's move to trigeminal neuralgia. In this scenario, they will mention a repetitive pain on the unilateral side of the face, including the cheek and the lips. It usually occurs for a brief period, but it is quite severe. It can occur 100 times a day. And the triggering factors which cause it: touch, shaving, and chewing. It is also associated with multiple sclerosis. It is basically due to the demyelination of the fifth cranial nerve and involves the branches like V2 and V3 but can also include V1. Treatment includes carbamazepine, gabapentin, pregabalin, amitriptyline, or glucocorticoids. And if medication fails, surgery is the next option. Give a quick rate to this slide and the scenario question. You can pause the video for a while and read it. Let's move to our next topic, migraine. There are different kinds of headache like cluster headache, which involves only one eye, or tension headache, which forms a band-like pattern and is usually bilateral. But in the scenario of specifically migraine headaches, they will mention a unilateral throbbing pain, which would be pulsatile in nature, along with phonophobia, photophobia, vomiting, and nausea. Phonophobia is the discomfort with voices, and photophobia is the discomfort with the bright light. They will also mention a family history and an aura period, which includes irritability and behavior changes before the migraine attack. If the migraine occurs without aura, it is called as common, but if it occurs with aura, it is called as a classical migraine. Migraine usually occurs with the triggering factors which are preventable, such as lack of sleep, stress, loud noises, and irritation. When it comes to the management, the first step is to prevent the triggering factor, and the remaining management is linked to the symptomatic treatment. Like for the headache, you can give the aspirin and analgesics like low dose NSAIDs. For vomiting, you can give the antiemetics like metoclopramide. In the treatment of migraine, you can also give somatriptans. Migraine is diagnosed clinically, but if there is a repetitive pattern or there are more attacks in a very short time, then in this case, get the brain imaging done and give the prophylactic drugs too. And if a woman has migraine with aura and she is using OCPs, ask her to stop the use of the OCPs as it can worsen the condition. Take a quick look at the next slide and you will notice the duration of the migraine can last between 4 hours up to 72 hours, that is for 3 days. And read the past paper scenario. That's all for today.